he's Soha is for me this is the first time I meet Sudanese OT actually working in mental health حقيقة يعني. وأنا أفتكر that would be the case for many people in this meeting. It would be a good opportunity actually to hear from you, Soha. So Soha Osman, she's a senior occupational therapist with over 12 years of experience in occupational therapy, hospital development, and commissioning project management, clinical rehabilitation, and training. Suha has a Master of Science degree in occupational therapy from Queen's University and a Bachelor of Science degree in neuroscience and psychology from the University of Toronto, Canada. She has worked in various posts clinically and in research, such as Peter Para Regional Center, Providence Care Mental Health Hospital, Sydney Brock Hospital, Toronto Western Hospital, and Queen's University. Suha also successfully led the development of the occupational therapy development and services and aided in commissioning a new Center for Excellence and CARF accredited mental health and addiction rehabilitation hospital in Qatar. Throughout her career, Suha has been recognized as a passionate and dedicated therapist, as well as a subject matter expert in occupational therapy and service development, utilizing evidence-based practices supported by research. She has participated in various community educational and awareness campaigns in Canada and Qatar, presented at international conferences, and has served as adjunct academic staff at Queen's University. Soha is a licensed occupational therapist in Canada, Qatar, and the UAE, and is a member of the Canadian Association of Occupational Therapists. Her clinical expertise areas. Can you please mute your? Okay. Soha is a licensed occupational therapist in Canada, Qatar, and the UAE, and is a member of the Canadian Association of Occupational Therapists. Our clinical expertise area include forensic psychiatry, addiction, medicine, rehabilitation, and mental health recovery, and community reintegration. Soha has received training in motivation interviewing, mindfulness intervention, early substance use disorder recovery, and concurrent disorder management. She is currently working as a senior occupational therapist at Mosley Health Al Amal Hospital in Dubai. Wow, I mean, that's a very rich CV. We are really honored to have Soha for the first time with us, and looking forward to hear the presentation. It was my honor actually to work with Soha as my colleague on the Mosley Health for about 1 year. And although we haven't worked in the same team, but you always hear a lot of good things from her colleague in Mosley Hospital. Thank you, Soha. The flowers is yours. Thank you.
شكرا جزيلا دكتور عبد العظيم, and it's actually يعني شكرا organizing committee for inviting me and letting me volunteer and and talk a little bit about OT in mental health settings. So I am gonna hold on again. I'm not the greatest with technology, to be honest with you, so hopefully I will see. I'm just gonna reshare again. Just give me 1 second, please, and I'm gonna share. Okay, I think this is the one. Okay, so okay. So again, today we're just going to talk a little bit about, and I know actually it's kind of the time is precious for everyone, so I'm going to keep it, nice and short, inshallah. So for the agenda, simply we're just going to talk a little bit about occupational therapy profession, the history, the background of it. We're going to talk a little bit about the link of OT and recovery, and again, like we just talk about it from a mental health perspective. And lastly, we'll talk a little bit about what is OT in selected mental health settings. So just to start things off, and I know تقريبا we have about 20 something people. This session will be an interactive session. We'll do a little activity at some point, and then we'll be doing some discussions and everything like that. What comes to your mind when I say occupational therapy? Like, what is the first thing that comes to your mind when I say OT? So the floor is open for anyone to kind of share their thoughts or their experiences.
طيب بس تنويه للمتدربين our trainees. This is يعني mainly for you. في عدد من السايكايتريست حاضرين، نرحب بهم، دكتورة عيشة، طيب سراج الدين، إسراء بلة. لكن أنا عايز الانتراكشن from our trainees please. يعني I want you to interact with this session. Thank you.
شكرا دكتور. So yeah, occupational therapy, anything comes to mind? Have you guys, have anyone worked with OT in the past, or occupational therapy? Lena. اتفضلي يا لينا.
My understanding, my very immature understanding of occupational therapy, that I think every mental illness or every mental ill patient will be disabled at some point, so they will not be able to fully function. So what I understand is occupational therapy deal with this part of the mentally ill patients, and how can we re-engage them to again be at functional again, so to
Yes.
restore this part of their life.
Oh, perfect. Thank you, Lena. Yes, spot on. Yes, great. Now, have you worked with someone in the past? Well, you haven't worked with any OT in the past, Lena.
No, actually all my experience in Sudan, so I think we are not really advanced in this area.
Yeah, unfortunately, because I know actually even when I went to Sudan, and there is no OT profession للأسف هناك. They have physio is very advanced and is very intense over there, but there is no occupational therapy. So yeah, so thank you, Lena. Anyone else? Anything that comes to mind? There's something in the chat, one new message. Train patients, okay, so Lubna mentioned train patients to obtain main skills starting from daily activities, simple occupations to provide for themselves. Correct, yes. So thank you very much, Lubna. So yeah, so pretty much, hold on one second, what am I doing here? Okay, so yeah, so basically, as you guys mentioned, like we talk about like disability and retraining people to get back into the daily activities, whether it's like their ADLs, which is activities of daily living, or something else that's more advanced than that. But I would like us to do a very brief activity, okay? And that's, I think, what I've been mentioning. I will try to share this, but before I do that, I just want everyone to think about a typical day in their week, okay? And I know that not every day is the same for a lot of people, but if you were to talk about like a typical day in your, let's say in your week or your month or what have you, and if you were to think about the 24 hours that you have, what do you do? Okay, so let's say if I were to, hold on, I'm gonna stop sharing this one, and then I'm gonna share something else. 1 second, since I cannot do that. How can I share my other one? Maybe this one? Okay, no, it's not this one. Sorry, I'm kind of having, again, IT difficulties, so if you bear with me, please. Where is it? Advanced video, no. Okay, I may ask Mr. Yasser, Dr. Yasser, Mr. Yasser, if he's there, if you can help me with this.
Yeah, المشكلة في الشيرنج ولا؟
أنا بس بحاول I want to share actually no, you know what, I'm just gonna share my desktop. خلاص, I'm gonna share my desktop. Okay, can you guys see this? جدول, yeah, look, you guys can see like a schedule sort of thing, and it has the time from 6 a.m. up until 5 a.m. It talks about the activity, what do you do, where do you do it, and with whom, okay? I will give everyone about 3 to 5 minutes just for you to envision. Let's say if you were to fill out this schedule, how would your day look like? Okay, what sort of activities are you engaged in? And when I say an activity, I mean like something as, I don't know, like something as simple as like, okay, well, I took a meal, for example, or like I went for a walk, or I went to work, I took care of my family, what have you. So anything you do in your day is an activity. Okay, what do you do? Where do you normally do it, and with whom? Okay, so I'll give you like about less than 5 minutes, and then we'll discuss it quickly as a group. Okay?
طيب لحظات الصمت دي الناس دي شغالة ولا الناس كلها صامتة ساكت شغالة في في الشغل ده؟ our trainees شغالين لأنه بعد شوية حيسألوكم مش كده؟ أنت عايزة someone to present for you ال daily activities ولا كلهم ولا شنو يا خد سحر؟ شنو المطلوب منهم؟
Yeah, so no, so basically I just want everyone to kind of like think about the day, what you do in the day, and then we'll discuss as a group. I have a question after. فعايزاهم
تمام
and everyone to
عايزاهم
kind of
كل واحد أوكي هاي
yeah.
هم بس عشان يفهموا الميشن دي بس أيوه أوكي good.
It's crucial to specify whether before or after the war. This is very interesting. Let's talk about the now. Let's talk about the now. And we can also talk a little bit too, like about that, because that's the question I'm gonna have for everyone after. For now, let's do it for the current time. Let's say the current week, let's say. وبعد كده we'll reflect it a little bit. Thank you, Lubna. Okay, so I'm gonna stop sharing this one. خلاص. I'm gonna go back to the presentation itself. علشان we will talk about the next one. Okay. طيب. Any thoughts? So now the floor is open again. I want people to kind of not necessarily to tell me exactly what they do every hour. Like, what are the common themes, or how do you normally spend your day? For people actually who've actually done it, is there anything surprising to you? Is there anything that kind of confirms something that you've thought about yourself or about your day or about your life, let's say? For Lubna, I know Lubna asked a question about whether it was before the war, after the war. The floor is open just for me to hear some reflections on how do you guys use your time? And once you've done this activity, what comes to your mind about your day and about what you do during your day?
Assalamu alaikum. This is Lubna. Oh, good evening. It's evening here. So good evening, and I want to thank you for your efforts to engage us in such activities. Yani, we're all thankful and appreciative for this. I asked the question because, like, after the war, most of the time with so many displacements, we lost our track of time and the feeling of feeling alive. And sometimes, most of the time, the routine would make you feel alive as much. The problem is after the war, when I took the first glance for on your table, I felt like my days are the same, and I don't have the I just lost the track of time during the day. I'm talking about myself, like I'm not working after so many displacements. I lost my work, of course, and everything. So it's more of waking up in some certain time at the day, and then doing the house chores, and then studying for a while because like we are preparing for our final exams. Dr. Abdul Ghani would know. And then after that would be engaging in like family activities, like taking care of the kids and the family, my father, my mother, and then just like the circle repeats itself now and then. So it's like there is no demarcation of because before the war, I assume most of us had like totally different life because we have had our activities in the hospital, then meeting friends, then having our personal activities like going on walks or reading books or anything like things like that, relaxation time. We used to have this like I would call it life before, but yeah, it's different now. So maybe like we are hitting some sort of monotony these days. That's why I just don't feel like it's hard for me to look twice at the table actually these days. I'm sorry.
No, it's
Um,
okay.
yeah, yeah, and thank you again. I think that's all.
No, really, thank you, Lubna, علشان it's a very thoughtful reflection on, let's say, again, like how your daily routine, let's say, before the war and after the war. And you're right, because displacement in such an event like the war, like it changes a lot. You know what I mean? And sometimes مثلا let's say لما نحن when we look at our daily routine مثلا let's say like before the war, for example, it seems from what you were saying is that your role, let's say, as a student, your role as like, as an employee, your role as a friend, for example, you know what I mean? Like all of that took chunks of time on your table, you know what I mean? Like, or on your schedule, for example. Like in me, مثلا, let's say, Hassa, it's more of like, okay, well, my role, let's say, as a friend might have shrunk a little bit because my friends maybe are not in the same place, for example. Like I'm just, I'm trying to, I'm assuming here, so forgive me if I'm assuming too much into it. لكن like let's say مثلا let's say again like your role as a student might have changed a little bit, you know what I mean? Again, the displacement have affected not just how we do the activities, but our roles and responsibilities and how we're able to kind of perform it in a different country, in a different place. Thank you for that, Lubna. Anyone else care to share? I'm gonna go to the comments. No one? Okay.
Hi, Soha. I'll do some sharing, Dr. Rama Kamal. I think I tried to do the exercise and I'm not a student, I'm a senior consultant psychiatrist. But what struck me very hard is that I work a lot. The context of the hours is actually more towards practice, work, studying, preparing, a lot of things. That's the whole chunk of the week was actually consumed by, yes, academic activities and whatever you want to call it, or work. And I think I need to make more space for human interaction, if I'm allowed to say this, and look at a different way. I don't know if that's helpful, but this is what struck me when I tried to fill it.
Okay. Well, thank you, Dr. Rama. طبعا full disclosure, Dr. Rama is a colleague and a friend. We used to work together in Nofer, زمانك. It's really good to see you here, Dr. Rama. So thank you for sharing that. And yes, sometimes sometimes like we go about our day without really reflecting that much on what we do with our 24 hours. Okay, and sometimes when we have that time to just sit down and kind of like really think about it and really think about, okay, well, I've spent, let's say, maybe, I don't know, like maybe 12, 14 hours, let's say, of my day in that. But then what about my other roles? What about my other value, the things that are valuable to me? What about maybe just balancing sleep, for example, like eating, going out, exercising, different things, okay? So when we talk, oh, sorry, one second. So thank you again for Lubna, Dr. Rama, and everyone. But then I just want you guys to pay attention now to if I were to give this same schedule to someone with depression, for example, how would you think the day would look like? If I were to ask someone who has depression, for example, to fill out this same chart, how do you think it would look like? And again, the floor is open for anyone.
Assalamu alaikum.
Salam.
So I think it's very minimal activity, if any, and very minimal interaction with people, if any, also. So I don't think he or she will be able to fill in the schedule as any ordinary person.
Thank you, Lena. So what do you think, let's say mostly, like let's say, so you mean actually that they won't be involved in a lot of activities or like or a lot of socialization, مثلا, right?
Yes.
Okay, well, what would you assume the most kind of like the, how would they be spending most of their time, you think, or where or with whom?
At bed, I think, or Soha in their home. That's it.
Yeah. Okay. Thank you, Lena. Appreciate it. Now, what about someone with a psychotic illness? Oh, sorry. Somebody wanted to say something.
Yes, hello. I'm Dr. Fatima.
Yes. Hi, Dr. Fatima.
Yes, I think it's maybe if you're depression or any mental illness, most people or most patients may be isolated, being isolated in their rooms, neglect self-care, isolation, really, and uh, sleeping all the time. I think this is the main things in my mind now.
Okay, sounds good. So again, like, so they won't be spending, let's say, time with people, right? And then where would be maybe like one or two places, for example, the activity may be like one or two activities, neglecting the self-care, neglecting kind of like connecting with other people. Great. Now,
Yes.
what about with someone with a substance use disorder, like someone with addiction? And let's say to make it, I don't know, to make it maybe like someone with heroin addiction, for example.
Mm.
How do you guys think this would look like?
Hello.
So, okay.
Yes, Yusuf.
Okay. I think that substance use disorder patient should be like busy most of the time because empty times may provoke him to go and seek for his for substance to be misused. This is the big point for me, especially at night. He should take early sleep and try not to have very to have an empty time.
Okay, so let's say, okay, so you mean actually, يعني, for let's say for someone in recovery from substance use, they would need to occupy their time, especially at nighttime. لكن نقول مثلا, if we're talking about someone who is actively an addict at this time, for example, how would an addict spend their day, let's say?
Searching for the
Okay, but most of the addict, it depends on his situation. If he is an employee, if he was student, if he was, it's depend on his current situation. But most of them are taking medication at night, especially at weekends, and most of them, especially who takes substance that make them hyper arousal or that make so he is his days are reversed. So he wakes up at the night and sleeping at the day
Okay.
mostly.
Okay. Mostly. Okay. Sounds good. Thank you. Mawadda.
Yeah, I believe an addict would be spending most of the time thinking, obtaining, using, or recovering from a substance.
Yes, for a lot of them, we see that. Yeah. So, and we'll talk about it as well a little bit when we talk about OT in addiction mental health settings. But what we tend to see, and again, like Yusuf said, that it depends. Let's say again, like on the on the substance itself. It depends on like let's say how functional the person is when they're using the substance or what have you. But for a lot of people, like the main activities, let's say, is how they can secure the substance and how they can, where they're going to use it, for example, and being under the influence of it. And then perhaps, again, let's say if they're able, let's say, to function with the addiction, then maybe they're able to kind of tend to some parts of their day. So let's say, for example, like if they're an employee, they may be able to, let's say, okay, well, they're just going to go to work, perhaps sign in, stay for a little while. They may use during the job, for example, they may leave early. It depends from one person to another, but we'll talk more about it later. Thank you, everyone, for your active participation. So now to the little, so it's going to be, when I say occupational therapy, I think a lot of you guys mentioned, again, the word function, independence. Just give me 1 second. And how we can rehabilitate people back into doing the things that they like to do. So again, it's we call it like the enablement of occupation. When we talk about occupation, I say an activity. So a lot of people actually, when I say that word, it comes to their mind, oh, well, it's their job or what have you. We call it the job of living, basically, right? So the things that they want to do, the things that they need to do, the things that they aspire to do, okay? And not only do we pay attention to those daily occupations of a person, but then we also use those occupations as a means of rehabilitating someone back. The areas that we mainly focus on are self-care, productivity. Now that's whether that's like, for paid employment, unpaid employment, education, education and learning, what have you, leisure and rest. Okay, so these are the main things kind of that we talk about, that we focus on. And when we talk a little bit about the occupational therapy history, generally speaking, a lot of people don't think, don't really realize this, but occupational therapy was originated in mental health settings. Back in the 1800s during the asylum, and now I'm talking kind of like, Europe, North America, Australia kind of areas. At that time, as you guys know, and of course I'm sure actually from your studies as well, the idea of asylum and like putting people who are the invalids or what have you, like in the asylum, and a lot of them, they would just be living there forever and they will not be engaged in anything because again, like they're kind of like outcast from society and they're just there. Adolf Meyer is a psychiatrist, and I'm sure you guys might have heard of him before. And he recognized the value of doing something purposeful in improving, let's say, the mental health of a person who was living in such asylum. Okay, that also helped with because at that time during the early to mid 1800s, there was the moral treatment movement, the arts and crafts movement, and people actually were changing how they view patients who were living in such asylum. Dr. Dunton, who's also a psychiatrist, and in the States anyways, they call him the father of OT, because he's the one who kind of like came up with the term occupational therapy and how we can use different occupations that are meaningful to the person, that are purposeful in nature, and that will provide therapy for the person who's living in such asylums. Then in the 1900s, we introduced the medical model into occupational therapies, because before that, and that's kind of like, that was like they used to call them like the basket weavers. So occupational therapy at the time used arts and crafts a lot, especially, let's say, basket weaving in a lot of like the hospitals and the asylums back in the day. But then therapy by Eleanor Slagle, and she's called the mother of OT, and I hope you guys can hear me okay. My internet, okay. Can you guys hear me okay? Just to check. Yes, no?
Yeah, can hear you.
Yes, because my internet was kind of acting funny. From Slagle, basically, actually, she's the one who kind of who initiated the first OT program back in the US. Okay, and then of course the UK kind of like took part after that. During World War I and World War II, with all of the soldiers coming back from the war, occupational therapy really was quite integrated in a lot of hospitals and a lot of like rehab settings at the time. The problem, Taban, was a lot of those soldiers who came back, they've lost lots of limbs, they've with the trauma that they've seen and everything. The problem was how can they reintegrate them back into the community? How can they reintegrate them back into life? So occupational therapy helped in providing them again with meaning and purpose through arts and crafts, or even actually through talks about okay, how we can help you return back to work, or how we can kind of like get you back into society after that. Okay, moving on. So yeah, so that's kind of like the background of it, that again, in mental health, actually, OT actually originated in mental health. But if you were to kind of like look at, globally speaking, occupational therapy is mostly seen, especially in the Gulf, and that was surprising to me, especially in the Gulf, like it's seen mainly in pediatrics, and it's seen mainly with individuals with intellectual disabilities, with developmental disabilities, with younger kids and all of that, or what have you, or in physical settings. And if anything, working in mental health is considered like a niche kind of field for a lot of OTs, especially at least here in the Gulf, like let's say like in lots of countries, in North America, I mean, in North Africa, مثلا, let's say like Sudan, حتى كمان, like it's not even there, unfortunately. When we talk a little bit about what OT is, and the things basically that give rise to OT. Again, so we borrow a lot from psychology, from the humanities, from social sciences, from the medical model, of course, because when we work, let's say, for example, in a physical medicine setting, our approach is different to things. So let's say, again, yes, we do focus on function, we focus on independence, we focus on rehabilitation and providing meaning and providing purpose to the person. But depending on the setting that we work in, our approach to it is a bit different, okay? There are different theories and models. So again, the model of human human occupation, which is more of an American kind of model, the CMOP, which is the Canadian model of occupational performance, the PAO, which is the person, environment, and occupation, and the Kawa River. Now, the Kawa River is more like Eastern, like let's say Eastern Asia sort of thing, more. So the idea is, and I will go a little bit on, over some of these theories later on as we go on. But again, OT has evolved quite a lot worldwide since the 1800s, since the 1900s. And as you guys can see now, like if you go to a hospital, if you go to a center, it's quite well known. However, where we work depends on the country. So let's say, for example, like in North America, like let's say, especially in Canada, for example, like OT is huge in mental health setting, okay, and in physical medicine and in the community and in different areas. Whereas, let's say, but then if you go to the US, the mental health is not that, it's not that big, let's say, in there. Whereas, let's say in the UK and Ireland or what have you, it's huge in there. But then again, you come to the Gulf and the Middle East or what have you, and you don't see it. You see it in certain settings and not the other settings, okay? So if you talk a little bit about mental health treatment approaches, okay, one of them again is the recovery-oriented approach, which is, I don't want to say it's a newish approach, but it's something actually that that's something basically actually that we're like, especially in OT, we embody the recovery-oriented approach, again, of like empowering the patient, being holistic and non-linear, and understanding actually that recovery does have its ups and downs, it does have relapses. OT is in its nature, like we tend to focus on the strengths of the person, and what we try to do is that we look at, okay, well, what are the internal resources for that person? What are the external resources the person has? What are the strengths that they have? And we try to maximize that. And then let's say if there are any issues with the person, then we try to kind of develop the skills that's needed for the person to do what they need to do in their daily routine or what have you. So that's a recovery-oriented approach, which is, again, very closely linked to occupational therapy itself, especially in mental health setting. The biopsychosocial model is something that, again, I'm sure everyone is super familiar with in psychiatry. Again, the biological, the social, and the psychological kind of elements of one's mental well-being. And then the PAO model, which is an OT model, and I use that a lot. So we talk about the person, the occupation, and the environment. And we believe the environment, not just the physical environment. And I think it's something that Ms. Lubna, I think, was talking about a little bit, about how the changing in the environment because of the war. يعني سواء كان the physical environment, the social environment, the cultural environment, the idea of, like, again, like migrating and moving from one place to another, that impacts the occupations or the activities that we do. Okay, so let's say if we talk about like someone with a mental illness, for example, okay, and that person is in a non-supportive environment, whether it's a physical environment or the mental or the social environment, for example, then they're not able to do their occupation. So you would see that those circles are not fully integrated or interlinked, let's say, and there will be more space, let's say, between those those little like circles. So the idea is how we can create cohesiveness, let's say, between them three, and we increase, let's say, like the interactiveness of those three circles. The CMOP-E, which is again the Canadian model of occupational performance with engagement, it has strong focus on spirituality. Okay, and when we look at the person, we look at the affect, their affective health, their cognitive, their physical health. We look at the activities that they want to do, like let's say the occupation, which is the self-care, the productivity, the leisure, and then we'll look at the environment at the end, which is the institutional environment, the cultural, social, physical. Okay. So that's basically some of the, one second, what is this? So those are some of the models that kind of like help guide our treatment approaches when we work with people with mental illness, okay? Now, if we were to talk a little bit about selected mental health settings, and I'm a little biased here because I'm kind of using my own experience. I've worked in forensic psychiatry back in Canada, and then now in mostly here in Dubai, and also in addiction, in substance use disorder center in Qatar. So I'll be focusing a little bit on those, and yeah. So in forensic psychiatry, so if I were to, going back to the interactive nature of our little lecture, have you guys worked in forensic setting before? Or anyone can tell me a little bit about forensic psychiatry? I don't know if you guys have had the training just yet, but forensic psychiatry or not, but what do you think? Well, what sets forensic psychiatry apart, let's say, from other mental health settings? The floor is open again for anyone to answer. Yes, so Mawadda says, yes, you did work, excuse me. We used to work at Abdul Ali Idrisi Asylum. I'm not familiar with Abdul Ali Idrisi Asylum. What is that? Lubna, if you don't mind elaborating. Or anyone, let's say, because I haven't heard of Abdul Ali Idrisi Asylum before. And do they have forensic?
دي مصلحة كوبر سابقا.
Okay, sure. Okay, I know Kobar. I know Masahat Kobar. Okay. And okay, so how was that time? And let's say the patients that you've seen, and were they able, let's say, to go back into the community afterwards? Well, how was it? Because I'm realizing that forensic psychiatry in each country is quite different, and that, of course, it will impact how it differs in the security levels. Okay. But then were the patients then able to kind of like go out مثلا بعد فترة ولا no? Lina.
I did forensic psychiatry for a very short time. So from my experience, so at Kobar or Abdul Ali Idrisi, it depends on the crime that the patient commits. So like can be guessed according to the crime, and some of them spend very long time, years in the asylum, and some of them just once their family accept to take them back, so we send them to their family, and that was a very huge problem, that most of the families, they weren't accept their patients again, or their the patients again to be in the family. So they live them for a very long time back there in Abdul Ali.
But then have you guys, let's say, like you guys have witnessed improvement in the patients, let's say, like in their mental state and in their ability to care for themselves and their function, right?
From my experience, it wasn't like so nice experience or pleasurable. So I didn't get the chance to see patients improved and just go back to their normal life again.
Thank you, Lena. Appreciate it. The reason why I'm asking, because Eva, let's say, okay, again, like personally speaking as well, like, so when I worked in forensic psychiatry back in Canada, the system there is different. So they've got so the forensic system is parallel to the criminal justice system. So let's say if someone comes in, like let's say they've done an offense, like we call the index offense, or a crime or something, right? And then they came to us, they assessed them and everything, and we found that they were either, that they were not criminally responsible for the act at the time. Then they exit the criminal justice system and they go into the forensic system. And then once they're in the forensic system, they're there for treatment. Yes, we have like a special court, let's say, like we used to call it at least in Ontario, the Ontario Review Board. So the review board actually will determine the restrictions on that person, but that person or the patient or whatever will be placed in the hospital. And then depending, let's say, like on how they respond to treatment, for example, how they're able to participate, let's say, meaningfully in rehabilitation and all of that, then they're able to gradually go out in the community, even if the family is not willing to take them back. Because over there, طبعا, you have their goal is for them to go out, you know what I mean, while managing the risk. So risk management is a huge thing. So a lot of the stuff that, let's say, we did as occupational therapists, let's say in forensic psychiatry, is not only provide all of the rehabilitation, kind of like all the opportunities, let's say, that we will provide for someone else who's not forensic, but we had to keep in mind like the risk itself. So let's say, like, for example, like if I know that there are certain activities, for example, like, or let's say if we're thinking that, okay, well, this person has progressed a lot and they're able to kind of get a job outside and all of that, maybe there are certain jobs that this person, because of their forensic history, because of their mental illness, are not supposed to be doing, because if they participate in it, it will just increase their risk. يعني مثلا, let's say, for example, like if someone's index offense was, I don't know, like maybe assaulting, not assaulting, maybe let's say like that person, while they were psychotic or something, they're not appropriate, let's say, with younger people, for example, right? So again, like, we have to think about, okay, well, what sort of settings, let's say, this person can go to once they're in the community. A lot of the work that we do is psychoeducation, whether it's in group or individual format. A lot of the people, unfortunately, we see, especially if it's their first index offense, they may not have had any, any psychiatry involvement, let's say, before, or any mental health kind of involvement beforehand. A lot of the time as well, we work on skill development itself. And that can be something as simple as, how can you take care of yourself? How can you, how can you cook a simple meal, for example? Like, how can you maintain, let's say, like, restful hours, let's say, during your day? How can you, let's say, establish some sort of a routine that's meaningful to you once you go out in the community? So for example, like some of the patients we saw, and that's why I asked you, Lena, about like, have you seen anyone kind of improve during the time or what have you? Because for a lot of people in forensic psychiatry, it takes them time. So let's say by the time they come to us during assessment, they may stay for like a month or two for assessment. And then after the court declares them as not criminally responsible, they stay with us for years sometimes. But I remember actually, like, we had few patients who did really, really well, that they were able actually to go back to university, finish their university studies, and actually have gainful employment. But a lot of our work as OT had to do with, let's say, working with the university itself. Working on how we can modify the academic program that's provided to that to the client, let's say. We talk about, let's say, finding appropriate housing, having appropriate community supports outside, and again, that's why I think, actually, unfortunately, depending on the setting, working in forensic psychiatry and working in rehab in forensic psychiatry is different from one country to another. So that's just something quick about forensic psychiatry itself. When we talk a little bit about addiction medicine and rehab, and so a lot of the work that we do is, again, doing an assessment about, like, the occupational performance profile. Let's say, like, okay, well, what are the roles, responsibilities, what are the hopes and aspirations, let's say, for the person, psychoeducation on relapse prevention, psychoeducation on addiction itself, coping strategies is huge. So let's say one of the things that, and maybe actually Rama, since she's here as well, we used to work on a lot before is stress management and how we can cope with stress while the person is out in the community. A lot of the work that we did as well focused on lifestyle restructuring. When we talked a little bit before about like how would a typical day for someone, let's say with heroin addiction, would look like, we've, at least for me anyways, like when I worked with patients with opioid addiction, a lot of them, especially let's say like again in that setting in Qatar for instance, their day would be like literally they would wake up, they would try and get their fix, for example, like they would, make their phone calls, make their connections, whatever. They would try to get the money to pay for the, for the dealer or the whoever, and get the substance, they use the substance, and then they'll be under the influence of that. And then by the time, let's say they wake up or they come to, it becomes a vicious cycle. So for a lot of them, when they come for rehab and treatment, and then you ask them, okay, well, now that you're in recovery, how would you envision your day? A lot of them are not able to even tell you what they want to do. They will tell you, well, yes, I'm going to go and I'm going to get married and I'm going to have a family and I'm going to get a job and life is going to be great. لكن المشكلة, the problem is the most valued role for that person during substance use or during addiction was their role as an addict. So for us to kind of like think about, okay, well, what other things that I can replace this addiction with? Okay, not the addiction itself, but like how can I change that role that I envision myself in? What are the things that are valuable in my life besides the addiction? Because the addiction now, which was a valuable thing, the substance was such a valuable thing for that person at the time. But once you take it away, what would you do with your day? And that's why we see a lot of people, unfortunately, once they leave, let's say, a rehab setting, for example, or the center or whatever, a lot of them, they relapse again because they end up going back to the same role, to the same, let's say, environment, to the same neighborhoods or what have you, and there aren't that many supports in there. So a lot of the time we work on, okay, let's just actively think about goal setting. Let's develop some of the skills that we need perhaps right now so that we can prevent relapse when we go out. Okay. Chronic serious mental illness, of course. So let's say I'm talking about, let's say, psychotic illnesses, I'm talking about depression, bipolar, etc. So currently, like let's say through Mosley in Al-Amal, there's a project of rehabilitating people who've been in the hospital for years and people actually who've had chronic serious mental illness and how we can get them back into the community. I think like Lena mentioned, a lot of the time families are reluctant to take in patients back. And unfortunately, for a lot of those patients, because they grew up literally in the hospital, they haven't had the skills or let's say the coping strategies even, or the ability to kind of care for themselves. Okay, so what we do a lot now is just to, live life basically. And it may sound simple, but for a lot of people who've been hospitalized and institutionalized for a long time, the idea of like, what do you mean I'm going to cook my own meal, or like making my own bed, or doing those smaller things, or like, me establishing friendships, let's say like outside of the ward, for example, okay, me going out in the public, interacting, let's say like with the shopkeepers, for example, buying my own things, having, let's say like a recipe to do something, buying my own clothes, for example, like washing my own clothes. For a lot of our work is working side by side with the patient to look at, okay, well, how would you envision living in the community outside? And a lot of it as well has to do with psychoeducation, but the illness itself, about, okay, well, what are my personal relapse signs? Let's say like when, maybe when I get too stressed out, then my delusions about others or about life, let's say, actually may come alive again. Building support, there's something that, unfortunately, we don't have it here in the UAE yet, but then I don't know, hopefully in the future, inshallah. Something called the Community High Intensity Treatment Team. So basically, actually, what happens is that for like, let's say at least, and I'm talking, let's say like back in Canada, what we used to have. So those teams would follow the patient while they're outside, and they will check in, let's say, with them like daily, for example, just to see like how you're managing, how you're doing. Try to kind of like notice any maybe like early relapse signs or such, so that we can intervene right away. Okay, and of course, like, depending, let's say, like, on how much that person is doing outside, then of course that intensity will decrease by time. Okay, and again, focusing on productive occupation, especially in the community, things like going back to school, for example, like taking on a volunteer opportunity, maybe caring for a friend or caring for a family member, working, even if it's for part-time. A lot of the work that we used to do in the past is called supported employment, and I think in Sudan there was something like that. I heard before, but I don't know exactly if it happens or not. But for people actually who have a mental illness, they go to a work environment that actually understands that that person needs such support, and then they're able to provide them that support for them to flourish in that job itself. So other settings, quickly, because I know actually because of time and everything. Camps, children and adolescent mental health, again, working in the home, the school, and the play, and their playground and the environment. A lot of, especially I think here in the Gulf, anyways, as I mentioned before, there is high presence of occupational therapy in the school system, let's say, and in the home environment as well, besides the clinics and the hospitals. In developmental intellectual disabilities, older adults, again, how we can support older adults while they're living independently, let's say at home or in their communities, working with mood disorders and eating disorders. I'm not gonna go kind of like in detail in that, just because of time, okay? So if we were to go back to our initial discussion we had at the very beginning, how do you think, let's say, and especially let's say for the trainees, in the future, inshallah, once you graduate and we welcome you to the working world, inshallah, how do you think your practice will change by incorporating occupational therapy? And the reason why I'm asking this question, because not a lot of people know OT in mental health settings in this region. So how would your practice change by incorporating OT? The floor is open again.
For me to answer this question, I need first to really understand occupational therapy. I think I don't have this thorough understanding of the OT, and a lot of time while you are speaking, things seems like psychotherapy or psychology, things that doing with psychologists. So I need to understand occupational therapy more to answer the question.
Okay, sounds good, Lena. So let's say like now, Lena, from this presentation we talked about today, what is your understanding of occupational therapy? Because you're right, because I mean, like, yes, say, so for a lot of people, let's say they would say, okay, well, you have your psychiatrist, you've got your psychologist, and you've got your social worker. Okay, so that's kind of like in this region I'm talking about, right? And a lot of the time, let's say the psychologist would work on, let's say, psychotherapy, right? But then from your understanding now from this presentation, how would you think OT would be helpful, let's say, for someone you're treating who has a mental illness, for instance, like let's say someone with schizophrenia, for example?
From what I understand, it will make sure, or let's say the day-to-day activity, ensure that the patient is engaging, and like, let's say, micromanagement more than just like doing sessions weekly and no one knows what happens during the sessions. And so I think it's from what I understand from the session, it's about very close monitoring for the activity of the patients.
Yes, exactly. So the activity specifically, right? So the focus will be on the actual things that the person would be doing. Because what happens, let's say sometimes, and that's what I'm seeing as well from some settings in let's say the patient, I don't know, let's say she's someone with schizophrenia, طيب, who've had, who was in school doing the law degree, for example, طيب, and then the onset happens. they're 24, 23, or whatever, and they develop schizophrenia and they're struggling kind of like going back to school, they're struggling, connecting again with their friends, connecting with their family. They will come to a psychiatrist. A psychiatrist will most likely, again, do assessment and everything and all of that. And they will, prescribe a treatment. But then what happens to the person after that, right? They may actually, let's see a psychologist, talk a little bit about CBT for psychosis and all of that. But what's missing sometimes is, let's talk about the tangible things. Let's talk about, okay, let's say now when you go home, what are you going to be doing? What time are you going to wake up? What time are you going to sleep? Who you will be talking with, let's say, who you're going to be linking with when you feel that a relapse episode is happening, when the negative symptoms are so severe, let's say, or something. Who's going to be your support person? Who's going to kind of like help you at least to get some, to get back on your self-care, okay? If you want to go back to school, you can go back, maybe you can go back to that intense law program, for example, right? But then how we can maybe think about something in alternative in the meantime? How can we maybe actually liaise with the university itself? So a lot of the time, again, occupational therapy, not really micromanaging, but it's more of like, let's set the stage and let's kind of like have a foundation of how you're gonna spend your day. What are the goals? What are the the more tangible and the reasonable goals, let's say, at the time, depending on your recovery and throughout your recovery as you progress. I hope that's kind of clear, Lena. I don't know if that kind of answers your question a little bit or shed some light. But I'm going to read some of the things here on the comments. We don't have a clear mental health act. The asylum, it depends on the conviction. Lubna. Yeah, that's true. And I think actually that's the thing. So it depends on the act, the mental illness, and the risk. So again, going back to forensic psychiatry, but that's the problem. No, there is no mental health act, unfortunately. And again, even that, it took them decades in certain countries to kind of like come up with that and to enact it. I believe it will have a huge impact on the overall outcome of the patients. And then Lubna, I believe it needs to be incorporated into follow-up visits with psychoeducation, correct? It will help with relapse prevention, Mohammed. Lubna, following patients' routine, yeah, and encouraging them to find what suits their capabilities and having more independent lifestyles with the patients, correct? So yeah. So that's kind of like some of the things, and thank you guys for your answers in the comment section. So in summary, and I think actually so let's say like in certain countries, for example, what happens is that, like let's say, okay, like in Canada, an occupational therapist can also be a psychotherapist. So psychotherapy is a MOHA protected act, which means that only people who are licensed, only people who are trained as psychotherapists are able to do that. In our let's say like in our education, in our studies and everything, we do learn principles of psychotherapy. So let's say, for example, like, like what are the principles, let's say, of CBT, of ACT, of DBT. However, if we want to become, let's say, like if I want to become an OT and a certified psychotherapist, then I would have to do something. I would have to do more training, let's say, like on those psychotherapy modalities. However, what we do is that we use those approaches and we incorporate it into our work. The main thing that we do, and maybe actually the thing that I want you guys to kind of take home with you, is that we use an activity as a form of intervention. So let's say, for example, like if I know that I analyze with that, let's say, the activity that the person has to do. I try to look at, okay, well, what are the things that can I adjust, let's say, in that activity, or maybe in the environment of that person, or maybe a skill that this person needs for them to do such activity or such occupation. Okay, so that's kind of like what we focus on. But then also we use different modalities from psychotherapy, from the medical model, from different, let's say, areas for us to kind of enable the person occupation at the end. Okay. So I will stop talking now because it's exactly an hour. And yeah, thank you very much for listening and thank you for interacting. I really enjoyed talking to you guys. And the floor again is open for any questions, thoughts, or reflections. There is one comment in the chat. 1 second. Thank you so much. You're welcome, Lubna.
Thank you, Soha. That's very nice presentation. Sorry, I was having problem with my Wi-Fi, so I'm not sure if my voice is clear. But that's very insightful and very informative presentation. Really, really very nice. Yeah. Okay, I think we'll open now for questions. Anyone? You can either open the mic or you can just raise your hand, and then I will see. Anyone have any comment, please, or any question?
I'll read the chat box as well because you're welcome, everyone, if there's anything. But yes, please, if you guys have any questions or any thoughts, or maybe again, like any experiences or any, let's say, any thoughts about like maybe how you guys can maybe improve one's recovery, let's say like a patient's recovery or something, and how would OT, let's say, like contribute to that, then we can talk about that as well. And I know it's kind of late at night, but anything as well.
إذا ما في زوج يسأل أنا ممكن أسأل.
اتفضل يا ياسر. اتفضل يا ياسر.
فبس يعني بس the question is about the scope of يعني occupational therapy between outpatient, inpatient. What is going to be يعني الفوكس بتاع الشغل دايما بيكون مختلف والجولز بيكون مختلفة. Can you just give us just a brief insight about how can that be different?
Sure. See, it's different. And so let's say like if I'm talking about mental health specifically, and let's say if we were to talk about هنا مثلا, let's say in the Middle East, okay, at least in the Gulf, okay? In an inpatient setting, let's say if we're talking about like addiction treatment or even serious mental illness or let's say forensic or what have you, the OT scope mainly is delivering group sessions, individual sessions that focus on psychoeducation and skill development, okay? Now, it can, let's say, like individualized. Now, individualized in a sense, let's say, like, if, for example, let's say, like someone with substance use disorder who is leaving to go back home, I'll sit with him, let's say, like, and we'll talk about, like, let's say, a plan for discharge. Or, مش a plan for discharge. Let's say, what are you going to do when you go out from here, You see what I mean? Like, we go through, some of the relapse prevention, how we can incorporate that in the person's day, for example, okay? So that's an inpatient setting. In an outpatient setting, it can also be like more of like a consultative kind of like basis, let's say, for someone to come in to consult on like, how, I need help, let's say actually with this one, let's say like I need help. Let's say for some people, they say if they're advanced, let's say like in their recovery, they will like, okay, well, I'm trying to apply for a new job, but I don't know where to start. So it will be like something specific as, okay, well, let's look together at like, the job market. What are the skills you have? Let's say, let's help prepare you, get a CV. Let's help kind of like prepare you for an interview. Let's say, and then let's say like once you're on the job, depending let's say on how much communication the patient allows you to speak with the employer, to talk about, okay, how we can modify the job itself for that person, okay? In the community بقى is different. Now I haven't really community mental health سواء كان هنا or في قطر, it hasn't, I'm just, there isn't really, I haven't really seen that. Like let's say if I was talking let's say like my previous job let's say back in Canada, it's even more impactful in the community. In a sense, we act as case managers sometimes, okay? Or specifically as occupational therapists. So let's say if someone is خلاص let's say is at home, but like they're still let's say struggling with I don't know, maybe actually some early relapse sign. I'm talking let's say about schizophrenia, for example, or something, okay? But again, they're trying to finish a school, they're trying to, maybe actually they're working part-time, let's say, to pay for the rent, or something. They're trying to kind of like, I don't know, establish a relationship, let's say, or something. Then we work closely with them in terms of like those specific things that they're trying to achieve. And let's say if it's just for the school, let's say for university, or something, we talk about, okay, let's talk about a study schedule, okay, we have something a bit concrete with that. We talk a little bit about stress management and coping strategies, okay, and how we can apply that, and we can enact that, okay? So the scope is that the thing is like about OT, and that's what I personally love about it. It's a holistic profession, and you can work in any setting, basically. okay? Depending again on your experience and your expertise and your training. Okay, so مثلا, let's say, I don't know, so let's say for example, مثلا, let's say if we go outside of the mental health setting, if we talk a little bit مثلا, let's say about pediatrics مثلا, so you have them in centers, like let's say the rehab centers or whatever. People مثلا, let's say you have you know, like learning disabilities مثلا, they may have like some delays in the learning, in their بيسموها شو مثلا, let's say like in their writing skills, for example, or something, in their ability, let's say, to sit still مثلا in class. They may be diagnosed, let's say, with ADHD, with different things. So the scope is quite wide, but at the same time, so what happens normally مثلا, let's say, depending on the institution, let's say, or let's say institution of the hospital or whatever, then each profession scope is quite defined. You see what I mean? So مثلا, let's say, like, you know, if I work in the community, maybe my scope, مثلا, let's say me and the social worker may overlap a little bit, but there are certain things that only a social worker will do and only an OT will do. You see what I mean? So it depends a lot on the setting itself. I don't know if that answered your question, Dr. Yasser.
Yes, it did. Thank you very much.
عظمة
Thank you.
ممكن
أيوة
نتكلم.
I think we can. Yeah, go ahead. طبعا تفضل.
شكرا سوها عثمان على ال very nice presentation دي. و occupational therapy is part of our multidisciplinary team. حقيقة احنا بندرس اليوم theoretical في السودان، لكن why don't you participate في creating this profession في السودان يا سوها؟ يعني انت وال other occupational therapists who did this specialty برا السودان, why don't you contribute this very important job in Sudan. البروفيشن دي مهمة جدا في السايكايتري في الجنرال ميديسين as well يعني. فنتمنى انه نشوف الاوكيوبيشنال ثيرابي بعد الحرب ان شاء الله في نيو ايرا ان السودان يعني. فشكرا فور يور برزنتيشن، وشكرا لكل الحضور والترينيز اللي شاركوا، وعدد كبير من السايكايتريست شاركوا. شكرا لكم.
Thank you very much. You know what, though, Dr. Abdul Ghani, متذكرة حتى كمان when we were in when I was still in Qatar, we did have a talk about this. I can't remember Dr. Muhammad. He was the, I'm sorry, like honestly his name just escaped my mind.
محمد عبد العليم. محمد عبد العليم.
لا. He was a consultant for developmental disabilities.
محمد عمر.
محمد عمر.
دكتور محمد
محمد عمر الطاهر.
Yes.
محمد عمر الطاهر.
ايوه بالضبط. So I think actually we talked about that before. لكن انا وقت ذاك اللي كان before, it was way before the war. I left Qatar in 2021 at the time anyways, but after COVID. So there were talks about that because unfortunately it's not well known and it's not there, and it's such a valued profession. I'm not saying this because I'm an OT, but actually because we try, so what I see مثلا, let's say personally now, you know, a lot of the patients, for example, in الأمل مثلا, ولا even in different places, you know, they would come, they would take their medication, they may sit for 1 or 2 sessions, let's say like once, I don't know, like twice a month, let's say with a psychologist, but then they still don't have the tangible skills that they need for them to live their lives. They may have it, and the thing is, like, unfortunately, as you know, like we have a lot of our patients who are not psychologically minded, okay? So a lot of them maybe actually they come from different backgrounds and they're not able to kind of maybe grasp some of the concepts, let's say, of psychotherapy. But then once they start doing something, once they find something purposeful that they can do, something that they will give them a feeling of accomplishment, and that's, I think, actually what we do well as well. And we do a graded exposure, let's say, or a graded approach to getting back into different occupations that the person needs to do. فإن شاء الله, hopefully إن شاء الله بعد الحرب وكده مثلا, yes, I'll, you know, to my honor صراحة. فيا
إن شاء الله if you just prepare a proposal or a pilot or plan ولا حاجة, we can إن شاء الله help and contribute in this issue إن شاء الله. شكرا لك.
Appreciate it. Thank you very much.
Okay, guys, any other question? Any other comment? Okay. Thank you very much. So this is very, very, very nice presentation.